All right, thanks everyone for joining us this morning via Zoom for this not new medium to any of us, but I guess new to, officially new to Grand Rounds. So thank you for joining us this morning. We have a fantastic presentation to start this off. Dr. Sherene Shalhub is going to be presenting this morning. I think she is not a stranger to all of us. She is an associate professor in the Department of Vascular Surgery here at the University of Washington. She has a long history within our department, having trained here both for general surgery and for vascular surgery, and has been a long friend and contemporary of mine since we were in the same kind of venue of training. She has a fantastic role that she has really brought to the University of Washington, being the director of our multidisciplinary vascular genetics clinic. She has a particular interest in aortic disease and genetic-based aortopathies. She is actually both nationally and internationally involved and known for her work in this. But despite all of her accolades and accomplishments, I think what she's going to bring to us today is not only perhaps something slightly different from her area of research, but something incredibly timely and also, I think, incredibly helpful for so many of the things going on in the world today associated with COVID-19 and all of us in our work. So Dr. Shalhub, thank you so much for being here this morning, and I'm excited about your presentation.
Thank you, and I'm appreciative for the opportunity. And so I'll start with my disclosures because this is what we have to start with normally. And this talk was arranged a while back, a few months ago, way before COVID times. And my plan was to talk to you about patient engagement and research, but then COVID-19 happened, and the world has basically turned upside down. As you can see, at least from a surgical perspective, one of our colleagues here, Dr. Davidson, was part of this study where that showed that the pandemic itself has delayed 28 million elective surgeries, and there's really not a place on Earth that has not been affected where surgeries are performed, if you can look at this map. And then we hit this landmark of very unfortunate 100,000 lives lost during this time. So with that, there's a fair bit of grief, of course, and difficulty dealing with this. And the cases continue to rise across the world. It's interesting because when the work I'm going to present to you had a fair bit of response from Brazil, and so you can see that Brazil now is second to the United States in terms of numbers. The other thing we learned is that, unfortunately, this disease does not affect all races equally, and this is seen across the board. Anywhere that follows state numbers, you can see that at least at our local level, even the Seattle Times has shown that you can see that the disproportionately affected Black and Hispanic Latino populations and Asian populations compared to Caucasians. And then, as everyone is aware of what has happened over the last week with the issues with, bringing racism to the front page and with, not uncovering something that is hidden, but bringing it really to the front and the culmination of events. And now this is affecting many of us, many of my friends and colleagues in ways that I can only begin to comprehend. And so I do want to acknowledge that while this data that I'm about to show you predated at least the last set of current events, I want to say strongly that we, me personally, and we as an institution condemn racism on every front, and I see you and I hear you and I'm here for you. So I just wanted to at least acknowledge that in the beginning. And so what I was going to talk about over the next 40 minutes or so was about this survey that we had put together. And the reason for this was to get a better understanding of the personal and professional COVID-19 related stressors that are affecting the surgical workforce, and in this particular circumstance, vascular surgeons, and to understand the coping strategies and support structures that are available to them as they're dealing with this pandemic and with the changing environment, and also to identify opportunities in order to support surgeons. And what I hope is that when you're listening to this talk, that you will think about the ways these events have impacted you personally and how you are dealing with this and channeling this information and how this affects you on a personal level as well. And what I would hope is that we would walk away with an idea of how, as we continue to move forward, how we can continue supporting each other both personally and professionally. So we're going to go back to March 20th, 2020, which seems like a long time ago. And this was, at least on the vascular surgery world, Dr. Starnes and Dr. Singh had published an article based on what their information that they received from their contacts in Italy. And Italy at that time was dealing with a substantial amount of cases at that time. And this was, one of the early, if you will, letters to ask people to pay attention to the impact of this pandemic on the vascular surgery practices and the importance of basically adjusting our practices. So you can see during that same time, around that time, the numbers, this was one of the figures that was posted frequently where they were following the number of cases in Italy, and you can see the numbers in the United States were beginning to rise at that point. And again, here's a picture from Seattle Times showing the increased numbers of cases around that time. Additionally, in the vascular surgery world, this VASCON began circulating. This is by Dr. Tom Forbes. Some of you are familiar with him. He's in the University of Toronto, where in a way he was trying to systemize a way to prioritize vascular surgery cases. And vascular surgeons were in a unique conundrum because our cases, most of them are not really what we think of as elective per se, but we definitely put a fair bit of patients on hold during that time. The other thing that happened around the same time is that there was this WhatsApp support group that was initiated by one of the vascular surgeons, Max Bullauer, over at the University of Colorado. And within days, it reached the maximum capacity of WhatsApp at that time. And what was remarkable about that is that we were sharing stories about how our hospitals were dealing with this pandemic, how we personally were dealing with this pandemic. And it was this organic peer-to-peer support platform where we shared pictures of the empty grocery stores and so on. And then Zoom, involved our lives in a very substantial way. In my research, because a fair bit of it is collaborations across the world, Zoom was a very comfortable platform. That said, a lot of people are now very comfortable with it, and so that's one of the side effects, if you will, of the COVID-19. Additionally, social distancing changed our lives, as you know, and you can see around here, I marked the timeline around April 6th. My colleague and I, Nick Moad, who is a vascular surgeon in Michigan in private practice, and I reflected a fair bit on this socially distant yet never closer, because in a way, despite the fact that we are all, quote, staying home, there was definitely a lot more time to foster new relationships using these digital platforms, which was fairly substantial. And as a consequence, we wanted to really examine the impact of COVID-19 on the vascular surgeons. And in a way, and I'll circle back to this idea, but this was a way that we personally were coping with the pandemic by trying to at least make some sense out of it and finding ways to help others. So this was an anonymous cross-sectional global survey. We incorporated two scales that are validated. One is the General Anxiety Disorder 7-item scale, and the other one is the Brief Coping Orientation to Problem Experiences, Brief Cope, which measures how people cope with stressors. We also asked specific questions about COVID-19 related stressors and had a qualitative portions where people can write whatever they felt at the end of the survey. We disseminated the survey between April 10th to the 24th, so a very short amount of time. And we blasted basically every medium we knew to reach as many people as possible. One of the discussions we had is that we wanted to reach everybody around the world. We didn't really want to calculate necessarily a response rate, but we really just wanted to reach people. And so the Society of Vascular Surgery supported this and emailed all their members. But then other organizations amplified this across social media and as well people through their email accounts and through Twitters and so on. So you can see here that we had over 1,600 respondents from around the world, and this map shows you the highest frequency. So the darkest colors are the highest frequencies, with the exceptions of the three that really had the highest numbers, which was nearly 700 individuals from the United States and almost 500 people from Brazil, and then 104 from Mexico, and then the rest of the countries. So we had 58 countries all in all. The majority were male, 71%, and we had 29% were women. In terms of where we were on the curve or the surge, if you will, you can see the United States was peaking at that point, and Brazil was beginning to peak. As you're aware, Brazil now is hitting their peaks and they're having the increased numbers. So at least the two largest countries were at different stages of the actual surge of the pandemic. In terms of characteristics, 15% were residents or trainees, so these were fellows and residents in vascular surgery, and then the rest of the groups were equally distributed among different phases or decades of practice post-training. And then you can see that 34% were in academic practices, around 4% in the VA, although there's overlap between these groups. And then you can see that we had a nice distribution of people in different kinds of practices, including 9% who were still in solo practice and 6% in outpatient practices only. This is the colorful slides of the talk, but we looked in the United States at the regional differences, if you will, by dividing them into 4 regions: the Northeast, Southeast, Midwest, and West-Southwest. So the Northeast in blue, at that time, they were definitely having the highest number of cases, particularly in New York, as you know. And you can see that there are some differences across the states in terms of impact on vascular surgery practices. And I'll take your attention here to elective surgeries canceled. So you can see that the majority had elective cases canceled. These are vascular surgery cases, and over 90% in majority of cases, with the exception of the West and Southwest, which was, again, lagging behind in terms of the curve at that point and had less numbers. We in the West region and Southwest had more ICU beds available, but you can see in the Northeast, they had less beds. But overall, most everybody, around 70%, had reduced clinic hours, and telehealth became a reality in the majority of practices. Over 80% incorporated telehealth into their practices. Redeployment was a hot topic in terms of asking vascular surgeons who are now staying home, but not really staying home, in terms of how they can contribute in ways beyond being just a vascular surgeon, and many of them were redeployed to the ICUs or to dedicated central line teams, if you will. And you can see that the majority, over 50% of the vascular surgeons in the Northeast took on these roles, and about a third across the rest of the practices. For comparison, let's look at Brazil. Again, they had the highest numbers as well, and you can see that in Brazil, similarly, they had the elective surgeries were canceled. They still also had reduced clinic, but other notable differences is that they had very few telehealth infrastructure at that time, so that was not incorporated much into their practice. What about occupational COVID-19 exposure? And again, we'll look at the 4 regions, and you can see that the highest exposure came in the Northeast, where people, around 40% of the surgeons, had operated or placed a central venous catheter when a patient with confirmed COVID-19 infections, and followed by the Southeast. And the lowest numbers were, again, in the West and Southwest. Similarly, we saw the same trend with people who operated, again, or performed a procedure on somebody who was later diagnosed to have COVID-19. In terms of how people viewed themselves as high risk, there was hot discussions about which patient population is at high risk for COVID-19 complications, and we asked that of the vascular surgeons, and you can see, again, people in the Northeast, the vascular surgeons there, over a third of them felt that they were high risk for COVID-19. This was interesting in terms of adequate PPE. This went on for weeks in the news and the media about how there are hospitals without adequate PPE, and certainly that letter that was sent early on advocated for, again, canceling cases predominantly to preserve PPE. And you can see that in the Northeast, or even across the board, about 80% had adequate PPE or a little bit less, which means that 20% of our colleagues were practicing in institutions in which they felt they did not have adequate PPE and were exposed. Preoperative testing at the time was not very common, so it was a little bit less than 50% across, a little bit more in the Northeast itself. In Brazil, you can see now the differences because they were on a different scale, if you will, or a different stage of the surge. And you can see that very few surgeons, around 10% or closer to 15%, perform procedures on people with COVID-19, but a substantial number of them believe that they were at high risk for COVID-19. And again, this possibly could be explained by the lack of PPE at their institutions, putting them at high risk for infection. and then again, very few preoperative testing at that time. So this is the results for the Generalized Anxiety Disorder 7-item scale. And the way this one works is that it's really 7 questions that asks people about how they felt in the last 2 weeks. And then you rank it based on whether or not you experience these emotions nearly every day or a few days and so on. And so the big one you can see is feeling afraid as if something awful might happen, becoming easily annoyed or irritable, being so restless that it's hard to sit still, trouble relaxing, worrying too much about different things, not being able to stop or control worrying, and feeling nervous, anxious, or on edge. And so in the orange here, I've highlighted those who responded as nearly every day, and the big one was feeling something awful might happen. And this was a theme that came up in the survey where there was a fair bit of uncertainty and fear of the uncertain that was going on in people's minds, or at least that they expressed. And you can see that, again, if you ask about over half the day, these numbers go up, and then substantially some days, several days during the last 2 weeks. Corollary to that is that you can see in gray here, these boxes show the people who said that they did not experience any of these emotions at all. So overall, when we score this, you're given numbers per each of these questions. They're scored based on how you answer. And then you are given a cumulative score, which goes from 0 to 21. And you can see that 46% of the respondents self-reported that they had no anxiety, or at least followed in the category or fell in the category of no anxiety, and then an additional 31% had mild anxiety. That said, around 24%, so 1 in 4, had moderate to severe anxiety around that time. So you can see that distribution there. We also asked about the occupational COVID-19 related stressors. And we specifically asked about worrying about work colleagues getting infected. We asked about information overload. This was a generic information overload question. We did not specifically say where you're getting the information, but we asked about, do you find this to be stressful? And we asked people to rank it as very stressful, somewhat stressful, or not stressful at all. We also asked about the impact on career advancement. This was a hot topic among younger junior faculty at that time. We asked about the stress of lack of PPE, adverse outcomes, terminating contracts of employees and those who deal with, have employees, and then donning and doffing, the process of donning and doffing PPE. So you can see around 20% or so across the board found most of these to be very stressful, or at least more now, you go up to 60% on worrying about colleagues getting infected. And then if you look at somewhat stressful, you can see across the board that these were sources of stress. And then again, in gray are the people who felt that these were not stressful at all. One of the things that was interesting was we did ask the question about COVID-19 related financial concerns and whether or not, again, they found it to be very stressful or not stressful at all. And we looked specifically about where you were in terms of your practice, whether you're in training or whether you worked for an academic center or the VA versus community versus solo or outpatient practice only. And what stood out is that clearly there was a stepwise increase in how people viewed stressful and this being a very stressful or stressful experience for them, mostly among those in solo and outpatient practices. But you can see the stepwise, and this varies by their payment models and how they are reimbursed. Additionally, we asked people about their personal experiences as well with the stressors. And again, you can see that worrying about family and friends getting infected was high on that list. We also asked about extra childcare responsibilities, and we were careful to ask that in a way to where these questions, people can opt out to say this does not apply to me, so that we can have a true denominator. For example, if somebody doesn't have children, they're then not saddled with extra child care responsibilities, or if they have extra responsibilities, but maybe they don't personally have children but are caring for others. But we wanted to make that a question that was open so people can comment on that. We also asked about the responsibility of extra home cleaning, empty shelves at the grocery stores, the stress of working from home, and then we even asked about domestic violence at home. And you can see that the biggest worry, if you will, or stressor was worrying about family and friends getting infected. And then the rest, you can see that around half the people had these worries. Thankfully, domestic violence at home was low, but not zero. So this is noteworthy as well. Additionally, we did some back-end analysis on this idea of modifying home routine after work. And as you can see here by the numbers, that most people had a separate changing area at home, but they were still continuing to use the shared spaces with their families, although some people stayed in a separate room at home, so they self-quarantined, and some didn't go home. This was a question regarding to what they have done in the past week prior to this survey. And so again, you can see that when you analyze this by degree of anxiety, there are increasing levels of anxiety by each level of this separation from your home environment, with the highest stress being, or highest anxiety in this case, being among those who didn't go home and stayed away. But even having separate changing area at home versus those who opted to have no changes, they reported higher levels of anxiety. We also asked about additional personal impact. Did they review their wills, review their medical power of attorney, disability insurance, and whether or not they discussed dying with their family members? And you can see that 1 in 3 people discussed dying with their friends and family. So this really hit close to home in terms of people thinking about their own mortality at around that time. Now, I'll spend a few minutes here talking about the COPE survey, the Brief COPE Inventory. The way this is structured is that it asks 28 questions that are then divided into 14 domains. The domains are then, of those, 2 of them are religion and humor, which are not considered active nor avoidant coping strategies. But among the active coping strategies, these are active coping. It falls under that strategy, which is trying to do things to make things better. Using emotional support or instrumental supports, these are like peer support groups and so on. Positive reframing, those are the silver lining, the people who find the silver lining in whatever circumstance they're in. Planning and acceptance, of course, which is the opposite of denial. The other one is self-distraction under avoidant coping strategies, and I'll spend a little bit more time on that later. And then denial, substance use, behavioral disengagement, venting, and self-blame. And so you can see that if you look at the way this scale works is that you have, I usually do this a lot, or I usually do this a medium amount of time, or I usually do this a little bit. And overall, this group is a group of people who practices active coping strategies predominantly over avoidant coping strategies, with the exception of self-distraction. Like I said, I'll comment on that a little bit later. The religion part was interesting in terms of comparing the United States versus Brazil. Brazil is a heavily religious country, and so this definitely played a prominent role in the coping strategies, but the rest of the coping strategies were similar. We also asked about social media because, again, these digital platforms have invaded our lives in a new way, if you will. And so you can see that on the left side of the screen is Facebook, LinkedIn, and Twitter. And definitely in the vascular surgery world, we have a very active Twitter sphere, if you will, with vascular surgeons that are quite active. And around 1/3 of the people who responded to the survey found that particularly useful. As you know, just to anchor things, the hospital town halls, which most institutions had hospital town halls to provide information, half the people found those to be useful. And similarly, SVS Connect, which is our digital communication platform that we have, or the social media equivalent that is not commercially based, like Twitter and LinkedIn and Facebook. So this is where vascular surgeons post stories or comments or cases. And again, half the people found that to be helpful. WhatsApp was definitely 60% of the case of the respondents, and that makes sense because we disseminated the survey among that channel, for example. And then you can see that 70% thought Zoom was useful, so that was interesting to see as well. So we then also performed this multivariable analysis to look at what are the factors that are associated with the increasing degree of self-reported anxiety. What makes you go from no anxiety to mild, moderate, and severe? And so this is, again, I always like to have the mandatory slide, just the mandatory busy slide, but I will break it apart for you here. So one of the things that stood out was gender. So women were more likely to self-report increasing degree of anxiety. And this actually is well established in the literature. And what was interesting, what led us to this finding is that when we did this analysis the first round, we factored in experience or decade of practice. with the hypothesis that younger people potentially may have more anxiety than folks who are older, or maybe vice versa. And indeed, there were differences with people in early stages of their practices having higher degrees of self-reported anxiety. That said, it turned out that this is predominantly because we had more women in the early stages of their career compared to people who have been in practice greater than 20 years. However, the association with the gender was definitely stronger than the stage of practice. The home modifications or home routine modifications that I mentioned earlier definitely stood out in the multivariable model as increasing the degree of self-reported anxiety. So was the stressor of donning and doffing PPE. And as a consequence, we in the vascular surgery world had multiple town halls led by the leadership of the SVS. And this was one of the issues that was addressed in one of the town halls about the donning and doffing and the importance of having these protocols at different hospitals. Also, there was a big concern about the potential adverse patient outcomes due to care delay, and you can see that not only just by discussions, but you can see it also by the increasing number of publications regarding this topic, and then financial concerns, which I outlined to you. We also asked the question about the coping strategies that would implementing a particular set of coping strategies make a difference. And in this case, you can see that all coping strategies across the board, people who are practicing them, had increasing degrees of self-reported anxiety, with the exception of those who partake in positive reframing. So these are the people with the glasses half full or silver lining type people. Practicing this particular coping strategy was associated with lower degrees of self-reported anxiety. And that makes sense in terms of feeling a sense of control, and reframing one's perspective can provide some sense of control over things that are perhaps uncontrollable. Again, showing you back that coping scale, these are the ones that stood out in terms of being significant in the multivariable model as being associated with increasing levels of anxiety. And again, self-distraction really was something that was used frequently among this group, as you can see, and I wanted to comment on that. So this question asked specifically about two things. One was, I have been turning to work or other activities to take my mind off things. So these are the workaholics among us who buried themselves in work. And I would argue that even putting together this survey and putting in the series of manuscripts related to that was at least my way of self-distracting and coping. And then the second one is doing something other than, or to think about it less, such as watching TV, reading, daydreaming, and sleeping. And this really resonated with the news that was talking about how the Netflix stock has surged during that time, and many people have used this as a coping skill as well. Thankfully, when you look at the other coping strategies, those such as substance use, behavioral disengagement, venting, and self-blame, they were used by some in terms of frequency, but the majority of people did not use these methods, or less people employed it, which is highly relevant because active coping strategies are usually thought of as, or are thought of as being a more efficient way to deal with the source of stress, rather than avoidant coping strategies. And this is worth mentioning a fair bit, and this was really the takeaway message from this work, was that summative hospital support. So hospital support was associated with lower, people who reported having high hospital support had reported lower degrees of self-reported anxiety. And what that means is that we asked specific questions about these hospital support structures. In the OR, did they have operating room protocols related to COVID-19? Did they offer preoperative testing for their patients? Did they have, outside the OR and in the OR, did they have adequate PPE? And also specifically about leadership styles. So those who perceived that their leadership was transparent and about COVID-19 management and planning, or were approachable in ways where support, if you will, was associated with lower levels of anxiety. We also also asked about awareness of wellness resources. These were wellness resources that we thought were available to people in vascular surgery or surgeons in vascular surgery. And you can see that the SVS, Society for Vascular Surgery Physician Wellness, has its platform. About 50% of the respondents were aware of this as a resource. You can also see the American College of Surgeons Wellbeing information is a little bit over 1 in 4 people. And then AMA also has a managing mental health during COVID-19. Headspace had an upgrade for health professionals, and also the suicide prevention lifeline. You can see that a little bit over 10% were aware that there is a suicide prevention lifeline available to them. Take a few seconds here to talk about qualitative analysis. This was the question at the end that says, do you have anything else you would like to share with us about your experience with COVID-19? So this is an open question where people can write whatever they want. And we did the qualitative analysis, and 3 themes emerged, which were noteworthy. One is the worry and concern for others. This is the worrying about their colleagues, worrying about their family members. And one of the statements that really resonated was that a large part of the stress that I am experiencing as a result of the pandemic is in relation to the responsibility that I feel that I have as a physician to advocate for the most vulnerable in our society, those who are being the most adversely affected by the medical and economic implications of this pandemic. So this was definitely a worry beyond just family and friends and colleagues. This is just worry for globally. As well. There was also the stress associated with having opportunity to partake in changing or addressing COVID-19 impact on our practices, again, was quite beneficial. And then the financial stress, again, stood out as a very strong theme. This is the heartwarming part of the survey. We took the information that was in the qualitative analysis, and the way this works is that it counts the number of times a certain word appears and creates this word cloud, where the larger the word, the more likely it to have been mentioned. And you can see that vascular surgeons, to them, patients are still front and center. This was the most common thing they wrote about in this qualitative discussion. So again, patients are at the center, and then of course COVID-19, and that makes sense. And so what we took away was that we learned about these higher self-reported anxiety and stress levels, that people were worried about negative consequences to care delays to their patients. They're worried about their family, friends, and colleagues being infected. And of course, the changes in home routines add additional stress, and so do the financial concerns. Hospital support being associated with lower self-reported anxiety levels was something that is significant and noteworthy, because this is something that is not especially costly. The testing itself is costly, and offering PPE is costly, but coming up with protocols, being organized, being transparent, these are things that are not costly and are their impact is quite substantial on just reducing the anxiety levels among people who work in these systems. So certainly these are areas in which vascular surgeons and surgeons in general can be supported at the institutional, regional, and national levels. And I think this whole experience gives us an opportunity to revisit wellness again. Wellness was a hot topic prior to this. Burnout was studied among surgeons. And, vascular surgeons specifically demonstrated high levels of burnout, both among the vascular surgeon workforce as well as the trainees. And there's a substantial effort by the Society for Vascular Surgery to try to mitigate these effects of burnout and retain the workforce. And so this survey has given us an opportunity to have insight into personal stressors and to remind us that it's really important to create space, that we can create this space to care for ourselves, especially as we have increasing demands for caring for the patients. And, we want to mitigate the impacts of COVID-19 to the extent possible, and we've shown that there are ways that this can be done. Additionally, the education about COVID-19 is very important, because a lot of people were concerned about taking the disease home with them to their family members. And so education about the transmissibility it could help allay some of those fears. And then also support from the hospital itself, meaning people can change clothes at the hospital or shower at the hospital for going home. And many have implemented those changes as well to try to combat these concerns. I also want to say about this concept of moral injury. A significant number of vascular surgeons were worried about the adverse outcomes in their patients, and and had higher self-reported anxiety levels. And that, we can hypothesize that perhaps that puts them at risk for moral injury, which can occur when we perpetuate, when we actually bear witness or can't prevent an act that conflicts deeply with our held moral beliefs. And one could say that even the current events contribute to that as well. Additionally, many of us have lost family members or colleagues who were infected by this disease or by the events that are happening. And the nature of our work does not allow for much time to process the loss and to grieve in a way that is therapeutic, if you will. And so it's very important, again, to think about this in the context of how can we support each other, whether it's peer-to-peer support or from leadership above as well. And in terms of hospital supports, again, relying on resiliency or coping mechanisms is not enough. And certainly I've shown you that the vascular surgeons, at least in the survey, have practiced large amounts of active coping mechanisms, and one can speculate that that's because they're a highly resilient group of people, but that's not enough to combat burnout. And so this is where, again, I call for this institutional supports with multidisciplinary teams that focus on the healthcare workers and the peer support program in order to offer that, and that's through protocols and then additional peer support as well. And certainly organizational resources are important, and I put in one of them. This is the American College of Surgeons resources for COVID-19's well-being, and it's actually worth reading if you have not had a chance to take a look at that. And I think perhaps the most important contribution of having this survey is to realize that there is a silver lining. And I use this picture because it struck me when I saw it on TV with the toilet paper wrapped up. Again, there was this whole drama with toilet papers being taken away. And so people are now making, or at that time, making bouquets, if you will, of it. But really, the most important contribution is to realize that we are not alone in this COVID-19 pandemic experience, and that it is associated with increased anxiety and stress to a group of people who are highly functional and adapted to functioning in high stress environment. And so acknowledging this may open this opportunity again to increase this sense of wellness and the willingness to reach out. And as I come to a close, and I do want to have some time for discussion by the group, but I wanted to thank everybody, these colleagues of mine that helped me put together this work, and all these organizations that amplified the message and disseminated the survey as well. And I do want to thank our actual people that work in our institution. This is a picture of us during one of the patients with COVID-19 in our, what I like to call the space suits. And I appreciate all the support that we have had. I feel very fortunate to work in the system that I work with. This cannot be overstated. I think you can see that we have been very fortunate by having lower number of cases than anticipated and then having tremendous amount of support. And so with that, I say thank you for your time and your attention, and I would love to open this up for discussion.
Sherene, this is Doug. I'll start and break the ice for folks. Thank you for doing this work and acknowledging your own self-distraction in doing the work through the pandemic. I was trying to figure out where I sat on many of the graphs that you showed. I found that one of my issues was kind of an annoyance irritability threshold. It just seemed like there was so many things that were difficult throughout trying to navigate our changes in what we were doing and how disruptive it and I guess unsettling it was for everyone, and including myself, and kind of changing rules by the hours that I think what I heard from faculty and residents and staff is just a confusion of what's the reality, what's the truth. And when we're working on wellness before a pandemic, do you have any thoughts on how the pandemic has maybe changed maybe our overall conversation on wellness? And maybe does it maybe make us approach it from a different angle or have a different consideration or a different light than maybe we had 3 months ago before all of this started?
Thank you, Doug, for sharing that. And the answer is yes. I think, again, the silver lining in this story is that it created a space to talk about wellness and talk about how we can support each other in a much more honest and transparent way. At least that was my experience with the colleagues, at least in all these chat groups, if you will. And what was interesting is that the president of the SVS, who has been in practice for more than 20 years, he commented on that nobody ever used this language when he was going through training. And yes, we know this because we hear it. But it used to be, at least wellness, this idea of wellness was like, oh, this is the new generation millennials looking to be well, and why can't they just strap up their boots and just do the work and stop complaining? And this created that space to say, look, I mean, these are major stressors affecting everybody across the board, and we have an opportunity to rediscuss this. I am looking forward to today's afternoon about wellness, and I know that has been in the works, but this is very, very timely. The other thing that this has given us the opportunity is to reflect on what we thought was important in terms of how we do things. I have said this before, I'm a fan of Zoom meetings. I think they're a wonderful way to communicate. It cuts out transport time. I don't have to sit on the road. I don't have to get into the car. I can be much more efficient with my time, and maybe now my time doesn't have to bleed into 10 o'clock at night every night. Maybe I can just be done by 6 because I've been far more efficient. So that's one example, at least for me, that I found it helpful. That said, I'm also aware that even the Zoom meetings have created stressors for other people who don't like the medium, right? So again, how do we navigate, how do we take the good from what we've learned and really try to set aside, we understand that it is stressful, but let's take all the lessons and move forward into a changed world, because it's not going to look the same.
Well, I'll just follow up about the Zoom and interactions, because I agree. I think that Zoom has created some great opportunities for us that is leverage for actually face-to-face interactions like we're having now, that solve some logistics and make some things easier. But I am starved for human contact. So I've been in my office suite as the only person in an office that usually has 10 people until yesterday, when I actually had some other people here, and another physical person was actually in my office for a brief period of time. And I realized, wow, this is really shocking. I've gone for almost 3 months except for kind of the clinical interactions, with only interactions over a computer. And I don't like that. I miss being able to be with a group of other people, with a group of our residents or a group of faculty, and having discussions like this, but with physical presence with each other. I miss that.
And I think there's an article in the New York Times that came out recently that talked about how introverts really enjoyed the stay-at-home experience. They felt that they didn't have to have that additional stress of constant in-person interactions, and it's like we flipped. The acceptable model has always been the in-person interactions, like this is how you should do it, but this allowed space for those people to voice how they enjoyed it. So I thought that was a very interesting article, and I think the solution is a hybrid of both. I think most everybody needs a combination, at least some element of both. So I thought that was interesting. And there's a comment here from Dr. Anderson. It says that you're hitting on a very important point, which is that wellness is more than a state of mind. Wellness also relates to workloads and demands. So how could wellness be monitored among faculty, staff, and residents? And I would argue that the 80-hour work week idea, maybe wellness was not in the terminology at that time. It was more of a safety approach. But part of that is to say, can we be efficient at doing our work and still having space to be with the things that matter to us, whether it's our friends or families or activities or getting out of town or whatever it is, to be really well balanced. I don't know, Ben, if you have any other thoughts on how you would advocate for incorporating that for the rest of the people.
I don't have I think that the question of monitoring in some fashion is important, and I don't think it's more than sending out questionnaires, but I know what's happened in other universities is that there isn't monitoring, and then something terrible happens, and then they go, gosh, we really weren't watching. There was a plastic surgeon at MD Anderson and there was a tremendous amount of regret at having not prepared. So we're having fantastic conversations. I'm really pleased with what the leadership that Doug is providing in terms of doing this. But there's a practical question about how do you figure out, are people really okay? And we're doing this in the context of a financial crisis where we're being asked to increase productivity by 20% without more resources. That cannot come without stress. Wellness will take a hit. And the question is, how do we keep track of it? And I'm hopeful that there will be discussion among the department about what does that mean and how do we do it? Because it's more than a state of mind. It's not just, if I think about it, I'll be okay. That works for a while. But after a while, there's more to it than that.
I agree with that. And I think one of the important things is to ask people how they're doing. I mean, genuinely ask them, not the superficial, hey, how are you? But really, if you're asking the question, be willing to listen to what comes up. And a good example of this is I was meeting with about 7 medical students yesterday, and we started the talk by, one of the students said, I'm sorry, I didn't finish the work I was supposed to do for this. And I said, well, I mean, let's take time and talk about what's going on, because clearly a lot is going on. And we spent 15 minutes in the beginning, so from an efficiency perspective, we spent 15 minutes not on the research work we were talking about, but we spent 15 minutes talking about what everybody was experiencing and gave them space to speak about it. And maybe it's more comfortable to do it digitally because everybody felt comfortable sharing what they were going through. But I think that was a good investment of time and at least making them feel heard and being there for them during that time. So that's one mechanism. But I agree with you. I think, we have to think how in a practical way, how do we monitor this without creating added stress, right? So the mandatory surveys create stress, right? I mean, if you're like, you have to fill out the survey or put in your hours every week. I mean, that adds stress as opposed to, taking away stress. I'm going to just read some comments. There's quite a bit of here. Dave wanted to know if there were some studies. So he's asking about the studies on the impact of COVID on vascular surgery patients with reduction in surgery. We know, at least from our study, that pretty much the elective cases were canceled. There's 2 groups. There is VERN, V-E-R-N, a group out of the UK, which is looking at the impact of cancellation of elective surgeries on patients. And then there is the COVID vascular surgery group, VASCO, which is similar to the surgery one that you have been involved with, that are also systematically looking through the United States cases to track those effects. We do know there's some early work that's coming out, for example, from New York, that showed that the number of patients with aortic dissections that are presenting to the emergency rooms has dropped substantially. And we also heard about that in terms of strokes and MIs. So clearly there is an impact, not only on cancellation of cases, but on the willingness of patients to present to their healthcare systems. And also you can see it through the ads on TV that say, hey, we're a safe place, come back, come see us. So I think there'll be more literature along those lines. And then there's a comment by Dr. Langdale. It says, do you find any evidence of surgeons feeling devalued, particularly those in private practice or were older, as they were not doing what they're trained to do? Obviously, does not apply to those re-upped for their ICU skills and certainly valued, but not for vascular surgeons. So overall, the anxiety levels were similar, at least, I mean, this is the way we could assess it by this survey, was through the degree of anxiety that is reported, and that was similar across the groups. So it was not like one group was particularly reporting more on anxiousness per se globally, but like I showed, there were certain elements that were associated with higher degrees of anxiety, like the financial hits that people in solo practices, for example, were taking. This was definitely a big deal for them. The other thing is that maybe potentially related to that is that people who, you know, there's a fair bit of people that said that working from home, over half of them said working from home was stressful. So again, that goes into the role of surgeons. We tend to be a gregarious bunch of people who are outgoing and thrive on social interaction and being utilized usefully and having value and meaning into their work. So, you know, I think going back to work now, I think will be one way to recoup that. But that time of this hiatus that people had was stressful to not an insignificant group of people. Let's see if we have. And then, so any comments on those so far before I jump to the next question? Dr. Langdell, I'd love to hear your thought about that. I mean, what is your perspective?
Well, I just noticed that it's just such a difference. I mean, we're so embedded in our job that we find so many people just find that their value is centered around operating and doing good for patients with the skills that we bring to the table. And that it's, you know, it was a big shift when the people who, I wonder if the people who coped the best were those who were actively asked to participate in meeting the challenge. That you either come up with protocols or you're advising people. I know for myself, my biggest plus has been in the time to think about and reimagine what the hospital might look like in the future, and say, okay, the place has been blown up. Let's think about how something could be done differently, and then you get to the frustrations of trying to persuade people to your point of view. But that, you know, it was difficult for me to not be in the ICU, to not be operating, to, you know, it gave me a real window into what retirement might look like. But the, you know, not that I wanted, and I realized I'm not ready to do that. But you know, I think there were differences. I was surprised to see how little anxiety was present for those who were older, mostly because of how embedded surgery is to our self.
That was, I mean, this is why we did the initial or one of the early analyses was trying to understand who was more anxious, if you will, about this. And that didn't seem to be the case. But I can, two things. One, this is a survey, so it's very, you know, it's quite possible that people can under-report on their experiences, if you will. I mean, it was interesting to see that there were, you know, a significant number of people that had no anxiety whatsoever. I mean, they just scored very low, despite the fact that we're dealing with a world pandemic. So that could potentially be one thing. There are literatures that show, like I said, gender differences in self-reporting of degrees of anxiety, that women tend to be more comfortable or at least likely to report those compared to men. So that could be another explanation. The majority of the people who were 2 decades or more into practice were men in this group. So that could be another explanation. The third explanation is maybe we are just a Zen, resilient group of people, and you know, making the best out of it. If you know, a third of the people were redeployed to other duties, whether it's, like you said, triaging or writing protocols or so on. So people managed to stay quite busy, you know, in general, and that's just the nature of surgeons, like you said. I mean, they're action-oriented in general. There's a comment from Dr. Bolger here. She is saying, about, talking about the moral injury associated with anxiety about the impact on patient care, both postponing surgeries, but also managing emergency surgery in this environment. In light of the benefits of positive reframing, this seems like an opportunity to capture the lessons we have learned now to reduce moral distress going forward. I would love to turn that back to you, Dr. Bolger. I'd love to hear your insight into this, because it's a big deal. I mean, there was a lot of moral injury happening from the standpoint of people having to turn away patients or not being able to provide timely care or delaying care. There was a lot of discussions on these groups, at least from the vascular surgeon's perspective, about the thromboses associated with COVID-19 in patients who were very sick, and the inability to revascularize them and then losing limbs and ultimately dying, or having dialysis catheters thrombosing and not being able to offer dialysis. So that created a lot of that discussion. So you can see it happening in real time. So I'd love to hear your thoughts.
Yeah, so really fantastic talk, Sherene, and I think it continues to focus us on how we address our wellness as a community. I was struck by your comment about positive reframing, because I think I've seen a lot of people who have taken this opportunity, I think Dr. Langdale alluded to it as well, to take a step back and say, okay, this didn't work, or wow, this was an advance, and how can we change our practice moving forward to to adapt to the things that we've learned. We don't know the future of this virus. We don't know what's going to happen in the winter. There's a lot of concern about a second wave, and I think from my perspective, at least a coping strategy for me, is to now, in this sort of period when things have calmed down from the virus perspective, to look at okay, what can we do better in the next wave? What are the metrics that we use to decide when to stop elective surgery? Should that be the same in everywhere in the country? Probably not, right? So instead of this is like something the college is interested in, but instead of like a blanket, shutdown, let's have metrics that we can use to guide those decisions so that we have the least impact we can on patients. What are the strategies we can do to make our emergency surgery, more efficient? We were very challenged in the trauma bay, managing complex trauma patients in airborne PPE because they're intubated and we don't know their status. And that, there's a lot of logistical things around that we are continuing to work on, so that, we don't get faced with another episode where we feel like the patient's being harmed because of our trying to protect staff, which was critical, right? It's a critical thing, but we need to do everything we can to sort of think through those things now, so that, if we're hit with this again in the fall, maybe we're in a better position and our patients are in a better position. That's kind of what I was trying to get at.
Thank you, and thank you for your leadership in that. I mean, this is, we look up to our leaders who are, paving the way. It's uncertain times. That said, this is not the first pandemic the world has seen in the last 20 years, right? We were not as impacted by SARS or MERS per se, although there's a lot of lessons even with those experiences that we can now implement and learn alongside with what we're learning today. And whether it's a second wave coming next fall or another pandemic that's happening that, in the future, I think there's a lot to be garnered and a lot of time for self-reflection. And all right, so I think we're coming down to the last minute. I just want to read Deb's comment here. About looking at wellness through the lens that COVID-19 has allowed and perhaps forced us to look through. So many of the aspects of wellness that have been impacted are the same issues leading to challenges with wellness and burnout prior to the pandemic. Moving forward beyond the pandemic itself, how can we use this advice for our own personal wellness individually and hopefully highlight changes that we can make in our medical system to advance wellness? So, I am definitely not an expert in wellness. I can tell you I'm very unbalanced and a workaholic, and so I am not an expert in wellness. That said, I would love to advocate for it, for all of us to learn together of how we can control our lives in a way that makes us a happier bunch of people and not burn out. I think the burnout discussion is a real discussion, and like I said, it was happening even before the pandemic. I'd love to hear your thoughts. Deb, I mean, since this is our last minute, so I'll give that to you.
Well, I'm certainly not an expert, I would say myself, and I often feel so imbalanced based, on so many aspects of life. But I love, and I shouldn't say love, but I think it's so valuable that, as you have so rightly said, it has sort of forced us to take a different look on wellness, other than just maybe, looking at it from a, external view, to say, how does this really impact me? What are the things that I can do myself to better myself, to better the system? And I hope that this can also translate into some changes. What are the things that were causing people to have issues in our health system? How can we reimagine it? Is utilizing telehealth as an adjunct? How is it going to, as an example, are there ways that we can optimize our health system, both locally and more on a national level, to make things better for ourselves and for patient care? So much, I think, of people's frustration with medicine is not so much that they are tired of caring for patients. We love caring for patients. It's so many of the other things beyond the actual patient care that cause a lot of stress, frustration, and whatnot of spending your time doing them. So how can we reimagine things to make things better moving forward? Because we've been forced to have such a dramatic change because of the pandemic. And I would hope that, on a glass half full perspective, which kind of tends to be my way to look at things, that maybe we will be able to use this as a positive, even though it's been a terrible experience globally and so much life lost. Maybe we can use it for the benefit moving forward.
And just in closing comments, Sherene, thank you very much for the presentation. And I want to remind all of the faculty and staff that we have our annual education symposium this afternoon, which I expect to be mandatory for faculty and residents to the degree possible. That starts at 1. It's on wellness. And I think there are some, besides the coronavirus pandemic, there are some other very important and current aspects that challenge wellness that I think we need to have some additional conversations about. I'll make some comments about that this afternoon for our wellness symposium, which I also just want to let everyone know 2 things. First, so that's at 1 on Zoom. It was going to be 1 to 4. We're now making it 1 to 3 as of yesterday, so that we can all attend the town hall led by our dean and the other health science deans regarding the aspects of institutional racism and the impact on that in our community. And we wanted to actually stop our normal education symposium to allow all of our faculty and residents and staff to join that. But I'm also going to make an announcement that there's organizing a Doctors for Justice march on Saturday that will go from Harborview Medical Center to City Hall with a goal of us wearing our white coats and demonstrating for justice and against racism, and demonstrating that as healthcare providers, as doctors, that the issues of institutionalized racism and the bias that exists for decades and centuries is a public health issue. It's not just a political issue. It's an issue that we care about as healthcare providers. So I just want to make that comment as well to encourage people, if they're interested, to join us Saturday morning at 9 o'clock at Harborview for this march. Just letting you know that I will be there. So we'll finish with that, and I'll see everyone this afternoon at 1 p.m. Thank you.
Thank you, everybody. Have a good day.